Good afternoon, everybody, and welcome. I'm Peter Hudson. I've got the privilege of co-facilitating the Palliative Care Research Network, along with Professor Jennifer Phillip from St Vincent's, the University of Melbourne. I begin today by acknowledging the traditional custodians of the various lands on which we gather and pay my respects to their elders, past and present. I extend that respect to all Aboriginal and Torres Strait Islander peoples here today. In brief, the main role of the Palliative Care Research Network is to promote activities that foster the evolution of collaborative scholarly inquiry in palliative care. It's been going for more than a decade now, and really the aim is to try and enhance the evidence-based clinical practice through connections and raising awareness about different research and its application to clinical practice. So delighted that we have these forums, and really pleased that you're able to join us today. And today's presentation links neatly to our Palliative Care Research Network aim, and it's my pleasure to introduce Dr. Caitlin Sheehan. Caitlin has been a staff specialist in palliative medicine at Calvary and St George's Hospital in Sydney since 2010. Her clinical interests include advanced cancer, cardiac supportive care, pharmaceutical cannabis, and virtual palliative care. Caitlin is a fellow of the Royal Australian College of Physicians and the Australian chapter of Palliative Medicine. She's a lecturer at the University of New South Wales, is an honorary fellow at the University of Technology in Sydney. She's held several roles with PACS, the National Clinical Trials and Palliative Care Collaborative, and CST Clinical Trials. Caitlin is passionate about providing best evidence-based care for patients at the end of life and enabling research to inform best practice in clinical decision-making. And as I said, well placed to talk on a topic that's very relevant to our Palliative Care Research Network. Caitlin's going to try and allow a few minutes at the end for some discussions and Q&A. So I think most people are probably used to the using the tab at the bottom of the Q&A tab, so you can post your questions. You can do those, post those along the way if you'd like, and that way we can then get straight into Q&A when Caitlin's finished. So on behalf of all of us, Caitlin, welcome, and I'll hand over to you, and we look forward to hearing your presentation. Thank you very much indeed.
Thank you, Peter, for that kind introduction. And thanks for inviting me to talk today to your network. I will just see how we go with sharing my screen. Are we working there?
Yep, all good.
Great.
Yep.
All right. So a few years ago, I had the privilege of being asked to be the program chair for the RAPID program, which is really an international program that prospectively assesses harms and benefits of interventions of both medicines and other non-pharmacological interventions in palliative care to really improve the quality of care for the patients that we look after. The RAPID team involves myself. There's a paediatric program lead. Oh, the paediatricians are amazing. The paediatric RAPID program is so successful in what it does. There's some pharmacists involved in it and pharmacologists. We've got some multidisciplinary, so we have an occupational therapist, a pharmacist, and currently waiting for our nursing member is vacant. So let me use this as a part of an advert for a nursing member. And we're supported by the national team who's based out of UTS and the impact there. So really, sorry, hang on, there we go. Current practice in safety monitoring, particularly for medicine, really involves kind of post-marketing reports from the sponsors or any medication safety updates, or really involves clinicians kind of putting in those TGA, I think they used to be called yellow card, to be able to report to authorities if there were any major adverse reactions. And really, action was only taken when problems were identified, but then it relied on clinicians to report those problems as well. So the pharmacovigilance and prospective studies, so these are all phase 4 studies, and it's really collecting the dearth that is around of real-world evidence of efficacy and harms that has previously been fairly poorly researched. we often directly extrapolate findings from other services, other patient populations into our clinical work. But that all isn't always as robust as we would like it to be because our patients are very different. And really, this real-world data provides an opportunity for us to better understand the net clinical impact. And by that, I mean the harms versus the benefits, and really for an array of interventions and medications. So the UTS Rapid program, as I said, is an international quality improvement program with a range of series. We call them each intervention is called a series. And we look at interventions, medications, and non-pharmacological in palliative care and cancer symptom management. And really, it collects data around those net clinical benefits and safety data of all those interventions. Small amount of prospective clinician-reported data at the baseline and then at certain time points depending on the intervention, with numerous participating sites worldwide. At any site or prescriber can be involved. So it's a really good way for sites that aren't really research active to get their toe in the water to clinical research. It definitely can be used to enhance local quality improvement. And I've got some slides about the accreditation process for different hospitals as well. And it's a very true prospective reflection of our day-to-day clinical practice. So where did we start? In 2011, not long after the inception of PACS, we started our first medication series, and that was looking at metoclopramide for nausea. At that stage, we were just doing one series at a time and sticking to fairly unique but robust and similar methodology for each of those series. In 2013, we did our first intervention looking at blood transfusions. In 2016, things moved a bit differently within the organisation of PACS, and so there were symptom nodes that were actually formed in terms of pain and gut dysfunction and dyspnea and nausea. And different symptoms. And so then we decided to kind of open up more broadly so that there could be multiple rapid series running at one time. In 2019, the first nursing series opened, which was interventions for noisy respiratory secretions. And boy, that was our fastest recruiting study. And then we added a sleep node. And so there was some new sleep melatonin and temazepam for insomnia, which were added as rapid series. And then in 2019, the paediatric crew got on board, and they're looking into paediatric palliative care, and then a couple of years later expanded into paediatric chronic pain. My computer's just beeping at me. So why is it called rapid? Well, we aim to get a large number of sites from across the world and across different care settings. And this is a little diagram of all the countries that have been involved in rapids, both active and inactive at the moment. And as you can see, 18 countries across the world and 120 active sites at the moment. Our rapid data collection for multiple series at once really is very de-identified type data. So we capture gender and age, importantly not date of birth. We look at the primary life-limiting illness, the phase of their illness, any lab tests, particularly if they're relevant to that particular intervention, the AKPS. We do some symptom scores around NCI criteria, both for efficacy and toxicity. We capture data on the dose, the frequency and the route of the medication, and also any of the interventions of interest or other interventions of interest. So it's usually a fairly quick process. It's not a consented trial. This is a clinician collecting data themselves about practice that has started. So a rapid series and a rapid CRF will not start until the clinical decision has been made to commence a patient on that particular intervention for the assigned symptom. We aim to have series open and reach a sample size. And at the beginning of the inception of RAPID, that was a priority set at 100 patients. We then leave the data open for a couple of weeks because sometimes those timeframes for time 1 and time 2 are a bit later. And then the database is closed, downloaded, it's tabulated with support from the National Office, particularly the biostatistician support. And then we're able to try and turn that around quite quickly and base the data on it on a publication, and then get it out towards into the wider knowledge of our specialty, so that people can really have influence onto their clinical practice. Again, we're aiming to look at the net clinical benefit. So I think in palliative care, we are often, or have been historically, very guilty of looking at a clinical benefit and thinking that it was our intervention, and looking at a deterioration or what might be harms and thinking it's related to the underlying disease process. So this is a way of prospectively, but really systematically, looking at toxicities of these medicines as well. And really, it's to help clinicians use the right intervention in the right patient and to reduce the potential harms to patient. And we hope to have the multiple publications. I think we're up to 15 publications now. We standardise the clinical assessment. We have a very standardised methodology, which I'll talk about later in terms of the ethical processes around this. We're recording these events in a systematic and consistent way, able to provide some feedback on our practice. Because of the wide reach of different sites, we're able to compare practices internationally, but also have some more generalizability of this work, and are able to provide an avenue for clinical research for people who don't have to have much in the way of significant resource implication. Really, all you need is access to the internet, because all it can be, and potentially even just a printer. If you can print out the CRFs, and then they can be uploaded directly onto our website. And really, it's about being part of that international community of practice. So in terms of the current RAPID series in the adult program I'm going to speak about today, we have 15 series open for data collection at the moment. There are 18 results have been published. Sorry, I said 15 before. We've got 8 of those, 8 further series in analysis or drafting stage, and 2 in the piloting or developing stage. And the current series we have open are on ondansetron for nausea, temazepam for insomnia, mesothelioma night sweats, melatonin for insomnia, some kind of more nursing-based ones, dressings for malignant wounds, diuretics for lymphedema, intrathecal catheters, and obviously that's a fairly rare intervention, and so some of these series are taking a little bit longer than other of those. Opioids for breathlessness, the use of medicinal cannabis, benzodiazepines for breathlessness, and then nursing interventions both for constipation and disorientation. And then kind of an OT-based one looking at compression and related physical therapies for lymphedema. Antidepressants for depression, and that involves both escitalopram and citalopram, and pancreatic enzyme replacement therapy for pancreatic cancer. We're in the process of looking at ranitidine and famotidine for malignant bowel obstruction, and also a handheld fan for breathlessness. So in terms of what this can mean for your sites in terms of quality and accreditation, so the National Safety and Quality Health Services has a lot of standards which those of you or anybody working in a clinical institution would be aware of. And certainly there's a lot of flow on from RAPID that definitely addresses at least standard 1 and standard 5. It definitely helps around the clinical governance and comprehensive care. Also a little bit about preventing and controlling infections, the medication safety standard, also blood management, particularly for the blood transfusions. And I guess also has some implications potentially for recognising and responding to the acute deterioration. And so there's certainly a lot that can be done in terms of getting sites active. And I think this is a really attractive quality, particularly for your managers, that this RAPID series helps to support these standards. In terms of aged care, there's definitely some aged care quality standards too, and we are in the process of trying to spread this out into the aged care space. But certainly there are the aged care quality standards. We meet a few of those standards as well. So I've just now moved to a bit of an explanation and some of the actual series that we've done too, just so you get a better idea of exactly how this process works. So first of all, haloperidol for delirium. So this is one of our earlier series. As you know, haloperidol is commonly prescribed for nausea, vomiting, and delirium in the hospice setting, frequently used in delirium despite little evidence. And this actually was a series that was done before Mira Agar's kind of landmark trial that I'm sure you're all aware of, published in JAMA. But this was a time in when antipsychotics were used very frequently within palliative care for delirium. We felt that there are a lot of potential harms, including central effects, somnia, sedation, restlessness, anxiety, incontinence, the cardiovascular effects as well, and of course the extrapyramidal side effects. So the aim of this study was to examine the immediate and short-term clinical benefits and harms of haloperidol for delirium in hospice and palliative care patients. The rapid methodology, as I said, pretty standard, usually 3 sets of time points: baseline, where the index symptoms and the symptoms that could reflect harm are gathered. For haloperidol, it was at 48 hours, where the index symptoms or the response was looked at, and at 10 days, particularly looking at the harms after commencing haloperidol. The participants were consecutive patients in participating clinical sites, started on haloperidol as routine care for delirium. So as I mentioned before, these rapid series really only come into effect once the clinician has already made the decision to commence that intervention for the specific symptom. And this was published back in 2013. So time point 1, we were recording the index symptom and the symptoms that were already there. So trying to get a sense of what those symptoms that may be toxicity were at baseline before we started the intervention or medication. Again, at 48 hours, looking at the response, particularly to delirium, and at 10 days following, looking at the harms, where we also got the clinicians to rate the severity of the symptoms, but also some impact on the daily living activities. And other impacts such as threats of harm to themselves or others. When we look at the results from this study, there were 119 patients, 14 sites in 4 countries. This was when we were only doing 1 at a time, and so things moved very quickly. And those time points and patients were collected from within a period of about 6 months. As I said, we looked at consecutive patients over routine care, and 88% of these patients had cancer. The mean dose was 2.1 milligrams. The route was parenteral or oral, and usually the frequency was a 24-hour frequency. In terms of the benefits and the harms, approximately 1/3 of participants and clinicians felt that the patients had a benefit at 48 hours, and 1 in 15 had this haloperidol cease due to harm. This was a mean elderly population of about 73, and they had poor physical functioning with an AKPS of 30. We looked at their mean comorbidities, and it was quite a comorbid bunch, looking at the Charleston Comorbidity Index. The most frequently associated harms were somnolence and neurotension. 7 of the participants had their medication ceased for harms, of whom 2 had somnolence and 2 had rigidity. So as you can see, this isn't the same findings, particularly as these larger randomized control trials, but it's a really good way of kind of seeing the lie of the land before we go forward to do those more complex, expensive and detailed phase 3 trials. The next series I'm going to talk about was the non-steroidal anti-inflammatory drugs for pain. And really it was felt that NSAIDs were considered to be efficacious and very cost-effective for pain, but there was the use was often limited by concerns from clinicians about the adverse effects rather than their lack of efficacy. So this study again tried to examine the real-world use of non-steroidal anti-inflammatories with associated benefits and harms. Again, same thing, 3 data points, which were at 2 days with pain and side effects, and at 14 days with pain and harms after commencing the NSAIDs. This was a poster that was presented at last year's OPCC in September last year. So this point again, time 1, again, similar to all, data recorded looking at the index symptoms and any symptoms that could be reflected in harm. Time point 2 for this series was again at day 2 with an assessment of the pain, intensity and the adverse effects. And time point 3 was at 14 days, particularly looking at pain and adverse effects. 92 patients completed data collection in this series, 14 sites, 3 countries. Inclusion, 91% of them actually had a diagnosis of cancer. In terms of cessation, NSAIDs were ceased in 23%. 18% went on to have a 2-week ad hoc cessation of their treatment, most commonly due to inadequate analgesia. And no patients were discontinued due to toxicity. In terms of the benefit, they felt at time 2, 88% had experienced some benefit, whereas 22% had suffered harms. And those were nausea, 8%, non-GI bleed, 3%, some kidney impairment in 3%, and vomiting. Only 2% were severe and only 1% was felt to be attributable to the NSAID. The mean age of this group was a little younger at 69, and overall 65% had experienced some benefit without harm, and 3% only suffered harm with no benefit at all. So I guess this was reassuring for clinicians who are often nervous about starting NSAIDs in our patient population, that NSAIDs might be an effective short-term analgesia, that most patients experience benefit after commencing, and only 1 in 5 was facing what was deemed to be actually a tolerable harm. Just grab a drink. The next series was looking at pregabalin and gabapentin for neuropathic pain. And again, this was a slightly earlier study. But we all know that neuropathic pain is common in people with cancer. It's frequently poorly responsive to opiates. There was increasing evidence for gabapentinoids at that time in the cancer-related neuropathic pain. This study was actually done before pregabalin was put onto the PBS. And the studies generated did not include many palliative care patients. Gabapentin and pregabalin have a primary role as the anti-epileptic and also possibly an anxiolytic. So again, the study was done where the net clinical benefit, and then we were able in this series to compare the 2 agents. So it was again the consecutive patients who were prescribed these medicines as part of their routine clinical care. These patients could be in the inpatient community or consultative, and it was widely throughout Australia, and it was for neuropathic pain. At the end, we had 127 for the gabapentin arm and 155 for the pregabalin arm, 42 sites for gabapentin, 62 sites for pregabalin, and 7 and 5 countries respectively. So again, lots of patients, a wide distribution of sites that are contributing to this data. For the gabapentinoids, we were looking at baseline data, again, looking at pain and the symptoms. Our time point 2 was at day 7 with immediate and short-term harms. And our time point 3 was set at 3 weeks, day 21, looking at the net clinical benefit of pain response. And you can see in the gabapentin arms, about 54% had a benefit, and in pregabalin, about 51% had benefit. In terms of the benefits, there was a higher proportion, well, now I've got to get this right. There was a higher proportion of those with gabapentin who had a benefit, but who also had a higher proportion of harm as well. And that was worse with people who have increasing age, of increasing comorbidities, and those on higher doses. Pregabalin had a 40% benefit with a 35% of harms, and 16% had a benefit with no harm. 10 of the patients ceased the medication due to harms in each study, looking at mainly for somnolence, fatigue, cognitive disturbance, dizziness, nausea, ataxia, and tremor. And you can see really that there was a similar pain resolution in both of the groups, but at lower equivalent doses of the gabapentin versus the pregabalin. And really those receiving gabapentin who had more comorbidities were much more likely to experience harm. So it gave us a little bit of information about medicines that are widely used that actually don't have very robust evidence base behind them. The red blood cells. We know that anemia is present in patients in inpatient palliative care units somewhere between 50 and 90%, definitely associated with a symptom burden. Transfusions are often administered to somewhere around 15 to 20% of palliative care patients. There's benefits and risks to the patients. It's also a fairly costly intervention, and there's obviously limited resources when it comes to blood transfusions. So this was to determine whether blood transfusions had any impact on anemia-related symptoms. And again, palliative care patients, mainly in hospice, these ones, I think. The baseline was at time 0, again, target symptoms and harms. At time, the T1 was at 2 days, and particularly looking at harms associated with the infusion itself, such as infusion-related reactions, fevers, extravasation, heart failure, anaphylaxis. And then at day 2 to 7, at day 7, which was time point 2, looking at the benefits in terms of fatigue, breathlessness, generalized weakness, dizziness, and other. So 101 patients were complete, 17 sites, 5 countries. This one took a little bit longer, I guess, because it's an intervention, and we were then opening it more broadly. Again, mean age of 72. AKPS in this group was a little bit higher at 49, which you'd expect given we're giving them blood transfusions. Their average hemoglobin was 72, so definitely within guidelines, and the malignancy was present in 96%. The people had an average of 1.2 infusions. The primary symptom that they were treated for was fatigue in nearly 60%, breathlessness 20%, and weakness in nearly 10%. In terms of the benefit, there was a primary target symptom benefit in 50%, and any target symptom in close to 80%, 78%. Those with fatigue benefited 47% of time, breathlessness 56% of time, and weakness around 40% as well. And in terms of harms, there was only 12% of patients who had harms, and they were pretty evenly spread across fever, extravasation, infusion-related reaction, and heart failure. Am I going for time? I've got a few more minutes, so I'll just quickly talk about the nursing intervention series, because I think this is a really interesting thing. I think there's a video that you can all look at later where Professor Jane Phillip, who's a nursing palliative care professor, speaks about how nursing, particularly in palliative care, is really a craft and an art, but this is a way to show that nurses are really interested in basing some science behind these interventions, these kind of caring interventions that they do. We all know that respiratory secretions are common at the end of life. And this was particularly looking at repositioning and suctioning, as these two interventions really have very limited evidence base. Again, this was published, this was a poster at the OPCC and is due to be published soon. These baselines were quite interesting. So you can see how we can adapt the methodology to the kind of sensible and practical real-world implications of the particular intervention or medication we're looking at. So baseline really was at type T0 and looking at the target symptoms. And they tried to get a few different ways of quantifying the secretions. So they looked at excess secretions, a respiratory distress score, and then the rattle intensity score, which is used in a lot of trials around this symptom, which looks at how far away from the bed you have to be able to still hear the rattle. And they also looked at other interventions as well. T1 was at 15 minutes, particularly looking at the target symptoms and any harms that were caused. And then T2 was done if re-intervention was required. So there were some people for which they had their symptom treated at T1 and didn't go on to need to be evaluated at T2. Again, 104 patients, 9 sites across Australia only. And this was very quick. I think this was back to the 6 months or less to be able to recruit to those 100 patients. 52% were male, again, fairly standard age for this rapid data, which was 74 years mean. 86% were in their terminal phase. In terms of other interventions, 30% were on oxygen, 36% had glycopyrronium or glycopyrrolate, and 9% were using hyacinth butyl bromide. The intervention that was under investigation was repositioning in 82%, both repositioning and suctioning in 16%, and suctioning only in 2%. In terms of baseline symptoms, mainly it was the excessive respiratory secretion, that rattle intensity score of greater than 2, which is audible at the door of the room, and also 63% had an objective look of respiratory distress. In terms of benefit, they felt that nearly 70% had at least one respiratory measure that got better. 52% had a reduction in their rattle intensity score, and 61% had a reduction in their excess secretions or their respiratory distress. They did feel that there was a worsening harms in 14%. Some of those were related to dry mouth, cough, and some worsening mucal ulceration, mouth ulceration. So as you can see, this is kind of now my promo of how to become involved. So anyone can become involved in RAPID. We invite you to become a member of either PACS or the Cancer Symptom Trials cooperative group. Really just express your interest in becoming a site. We have been able to get some sites who are able to waiver their ethics review, saying that this is all quality improvement and therefore don't need to have it. Or more commonly, we do have a lead ethics, which is really around the methodology. And then each of those series is built staying true to that methodology. Happy to join up, and you can choose to be involved in any of those 15 series that we have opened at the moment. And then data can be collected, as I mentioned, it's just through a link on the web. It's not needing to have a RedCap account or anything like that. There are some guides on our website. The website is there, uts.edu.au and /rapid. And happy to be contacted at any time with particularly using these addresses. I will leave you, I'm not sure, we probably don't have time now. Oh, look at me, I'm very clever, come right to the time. But there are some YouTube links as well if you want a little bit more promo video to see what we look like when we've all been made up and interviewed to do things. I'll leave it there, Peter, and I'll see if there's any questions.
Thank you, Caitlin. That was fantastic. Wow, this is quite amazing, actually. I was familiar at arm's length, but this really has been quite informative, to say the very least. What a unique model, and there's a few questions to come through. I've got a ton, but I'll go to the ones that have come through thus far. So Jenny's acknowledged that, similarly, that's such a smart methodology, and have you considered using this method for other populations or settings, e.g. respiratory or renal care?
Yeah, so there is a renal care that's under development looking at gabapentinoids. I think it's for restless legs, actually, and certainly the fan for breathlessness that we have pulled in that we're in the process of just completing the CRF. That's going to be piloted and then involved in lots of kind of respiratory clinics. So we've got respiratory clinicians from Australia and multidisciplinary respiratory clinicians from Australia, but also in Ireland, and different people who are actually on the committee, and then we'll open that up more broadly. So yeah, definitely. I think any of the interventions in any kind of supportive care space, it also fits very well to this population. The other population that I briefly mentioned is also aged care. So we looked at using the RAPID methodology to be able to get into aged care facilities, particularly looking at the use of antibiotics for common infections, and to see if there's benefit in those lot. Unfortunately, due to some of the aged care restructuring post Royal Commission, there's been a bit of a delay in that, but that's certainly something that we're very much looking into.
And would it follow, therefore, that there could potentially be the approach could be used for psychoeducational and psychosocial interventions, or you think that that's obviously would depend on how those, specifically what those interventions might be, and how you measure the outcomes? But in theory, do you see any?
Look, in theory, I think as long as it's an intervention that's started by a clinician for an indication, so therefore the psychosocial stuff would kind of fit that. We just need to be careful, because obviously patients aren't consented, and so often it's the clinician's impression of the change. And so when you get to the nuances of psychosocial interventions, that's where it possibly becomes a bit hard, because it's kind of, you're not asking the patient directly what the intervention, how the intervention has gone.
Indeed. Thank you for that. And Jen's also asked, based on the analysis you've done over multiple studies, what's kind of any major surprises, any sort of, really things that have kind of, fallen off your chair because such an interesting result or
If I fall off my chair very much anymore. Um, I certainly think the NSAIDs was a really interesting one. I think a lot of us are very nervous about prescribing NSAIDs in our patients because we think they're so frail and fragile. And I guess, there was nobody who stopped their intervention because of harm. So that was one particularly. And I think the benefit of the blood transfusions was also very interesting. And I think that was probably more than any of us had thought. I think the haloperidol for delirium is very interesting because I think that speaks much more to the idea at that time that clinicians really felt that haloperidol was helping patients with delirium. But actually, the findings in that study was only that 1 in 3 had a response. And so, it certainly wasn't the 100% that a lot of our clinicians at the time prior to Mira's big study thought. But yeah, I think they're probably the ones that have surprised me most. There's the pediatric pain population and the pediatric palliative care interventions have been amazing. And they, in the pediatric, we think there's not much evidence in palliative care, but when you look at pediatric palliative care, there's even less. And so those clinicians are so excited to be involved. They are going gangbusters because they want to have some evidence base to kind of guide their practice, and it just doesn't exist in the pediatric population. So this has been a fabulous movement for them. Ross is putting the adults to shame.
And in terms of fidelity, the intervention, so Jen's asked about that with regard to, how do you deal with potentially different practices at different settings and so forth, for example, in a compression for lymphedema or different doses, etc. How's that managed in the analysis? And
the analysis, definitely that's more problematic because we do definitely try and capture that. And I guess when each series is being created, we call for an expression of interest amongst our members and other interested people to get a range of kind of opinions around that, and a range of different practices, even at the outset of developing the CRF. Which hopefully then allows us to capture what the more common factors are. But I agree. I think the more, prescribing a dose of medication to be given in a certain way is one thing. And once we get into those bigger interventions, like the nursing series for disorientation, but I think it's just about capturing as much as we can at the outset and having that really kind of informed decision process at the beginning while we're writing the CRF.
Thank you. And less kind of focus on the intervention and the methodology, more on the managing expectations and the comms, etc. With so many partners, how do you does somebody have a job like the United Nations, and who deals with all the relationship development and maintenance? Is there somebody who's kind of employed in comms?
Yeah, there is. She's only employed a couple of days a week, but there's a project officer who is based out of UTS, and I couldn't, it's all really her, to be honest. But yeah, she manages all that and definitely getting ethics and having different sites through and things. I mean, we have enough experience now, and we've involved so many sites that I guess we have kind of precedent around negotiating all those things. For people to help people through to be able to get the ethics approval so that they can start doing these rapid studies.
And forgive me if you mentioned, but I misheard. Or in terms of how the funding model, how's that sort of?
There is no funding. We just she is a position that's funded around the kind of impact management team, and that's the funding. So there's no funding associated to this. We are relying on people's goodwill.
Okay.
And the time outset is very small. You can think about it, grab a piece of paper, fill in a few details for that patient. If you aren't collecting it as routine, if there isn't a blood that's already done, we're not asking you to do that. It's pretty low impact in terms, or low burden in terms of getting the CRFs completed.
Thank you. And a question from the audience: how do you join the interest group?
So by all means, become a member of PACS. And then if there is a particular, and then you'll be emailed out if there's an expression of interest. If there's something that you want to bring forward as yourself. So a lot of our chairs of our particular working groups and the committees for each series have just put themselves forward and said, I'm interested in doing this, can I do it? And then we'll guide you through the process. So just get in contact. Let me go back to my, can I do that? No, I seem to have lost my ability to go back.
Do you want us to put a link in? Was there a
yeah, there was definitely an email address there. So just to email union@rapid@uts.edu.au.
Not sure, Alfie, if you're on, if that's something, if it is possible, if you're able to put that in the chat. If it is possible, that's great. If not, we can circulate or make sure it's included in the video version of this
Oh, there you go.
Oh, yeah,
That
great.
works.
Thank you.
I've lost it, but
and in terms of back to the methodology, is it someone patented who's on here? Is it borrowed from somewhere else in other healthcare research, or is it novel to palliative care? This is a first?
I think it's pretty novel. I think it was
Right,
a thorough brainstorm.
right, okay.
Certainly Deb Rowett, who's one of the pharmacists, she was a part of it as well. But I'm pretty sure it's PACS unique. I haven't heard about it being anywhere else, actually.
Right.
I don't know if Jenny, you know about that, but yeah, I think it was a David Currow passion project.
Oh, it's fantastic. Jen's just saying it's unique. Thanks, Jen. If nobody else has got any questions, Caitlin, if you still wanted to, you mentioned before we came live that you had a 3-minute video. We have got time, and if you thought it would be helpful to the audience, but don't feel obliged, but we can.
Yeah, sure. Look, I love seeing myself on screen. But Alfreda, are you able to run it from that screen? I don't know if...
I'll try.
Thanks, Alfie. Thank you. But yeah, just congratulations again to you and your team and those involved. It's just, and I imagine for the international collaborators, for some of them, it'd be, I would have thought, extremely satisfying, right? With this, perhaps maybe their first time involved in kind of research at this level. Would that be?
Absolutely.
Yeah.
And I think, it is a really nice toe in the water for lots of sites to be able to get involved. Management, if they want to kind of, give you a bit of time or give you resources or access to the internet and a printer to do it. Obviously, the nice thing is around the accreditation stuff, that it speaks to that. But yeah, absolutely, it's a really good introduction. And certainly, even watching clinicians who've been kind of sitting on the sidelines of research who then come in and take a program chair and then are involved once the series has closed. Once we've written the CRF, it's piloted and then it's opened, and then we close once we've reached those 100s, or there are some other stopping rules, and then they're able to get a publication out of it. I think that's been an amazing site and a really big springboard for lots of clinicians who then go on to very big research careers.
That's such a good news story. Thanks, Alfie. I think we'll just go to the video and then because I think it's just a few minutes and then I'll come back on and we can close the webinar. But let's hear the video and see the video. Thank you.
Pleasure.
Just haven't got sound yet, Alfie, I don't think.
Oh, this is the David one. That's all right. There's two, but this is the other.
Have we got the wrong one?
Good too.
Are you sure? Because we're happy to. There's no problem. I think Alfie's having another go. And we'll see how we get.
Oh, Alfie, I was going to not have to look at myself on screen.
I'm sorry. I'm trying to connect with the other video.
That's all right. Take your time, Alfie. Even if it doesn't work, it's not the end of the world, so don't worry. Just while Alfie's bringing that, any other reflections from your perspective for potentially people who might be interested in joins or anything else? I mean, you've sold it to, I'm sure that people have, that you're a great salesperson for this, but is there anything else you'd want to convey just before we...
Look, I think that the community of practice is such an important thing. We can sometimes feel in a small specialty that we're all practicing in silos. And I think that community of practice and realising that we're all doing things fairly similarly is a really nice fringe benefit of it as well. I think it's, they're interested people I think also don't feel like you have to be a researcher to get involved. You know, we certainly can guide you through the process. Oh, it's blocked. You can watch the other one of David. But I think, you know, come put forward. We've had advanced trainees who've done projects. We've been able to help lots of people through different, you know, early career researchers, people who just want to get involved. People who've been thinking about research but don't have infrastructure support behind them. This is a great way to do that.
Terrific. Look, that might bring us to a close, unless there's any final questions. But Caitlin, just to thank you again. I think well, on a number of fronts, but in particular, you're involved in a very unique approach, but also your presentation skills. That was a lot of information delivered succinctly in a very digestible way. So, you know, well done, and thank you very much indeed on behalf of all of us for your time today and your effort in preparing the presentation. And I'm sure there's going to be potentially some other sites or other people approaching you for more information, I would imagine, as a consequence. And to thank Alfie and the team at St V's and Palliative Care for bringing this to fruition, and my colleague Jenny Phillip, who suggested you for this presentation. So thanks, Jen. Jen's always across the finger on the pulse of the latest in research in palliative care. So great suggestion, Jen. I appreciate you for that, and also your ongoing commitment to facilitating the Palliative Care Research Network. So thank you, everybody. Enjoy the rest of your evening, and hopefully we'll see you at another one of these events in due course. But thanks again, and bye for now.
Bye.